Good evening, everyone. I know we are running little late and we are waiting for dinner. So I'll keep it brief and quick. When Shivam asked me to do this, I thought that શું કરવું જોઈએ. It's not a very routine topic. So I decided that let's make it very practical and interactive. So we will go based on case. Um, So when we talk about rehabilitation, we have to understand it's a process. And the aim of the process is to help person achieve almost normal life after ailment or treatment of an ailment. Okay. Also remember that in cancer particularly, it's a physical plus emotional process. Only curing a physical ailment is not enough, but we also have to look at the emotional aspect or emotional toll that treatment has taken. So we want to execute this rehabilitation. I personally always compartmentalize into three aspects. One is predict. When you become a clinician treating many patients, you automatically subconsciously register that if I do this treatment, these are the problems that patient may face. Now, as a clinician, as a technical person, if you know that and you know your results before, you can always plan certain things that can prevent or minimize those problems. So for me, the rehabilitation process starts in mind from predicting, then trying to do things that will prevent or minimize, and then whatever the sequelae, we may have to plan a treatment for that. So with this background, I'll just say I was given for oral cancer, so we all know that primary treatment and main treatment remains surgery, followed by radiotherapy in most of the cases. And these are the common problems that we see, starting from lip, so anterior to posterior lip, then most of our patients have trismus, and if you remove one side of jaw, it's jaw alignment, tongue movement, related to speech and swallowing, then palatal defects, dental rehabilitation, neck shoulder dysfunction, then radiation side effects and all. Let's try to go one by one. So the discussion would be, I'll show a photograph and then briefly ask the panelists as well as someone from audience that predict the functional problems. In surgery, can we have certain decisions that can reduce those problems? And then when the problem occurs, we can ask the physiotherapist how we can do it. So let's start with the first defect. So this is a very common problem which we have. It's an angle of mouth involving cancer, and the treatment will result in loss of competence and the commission. So we can start with the surgeon Shivam. What would be the defect, Shivam, and what is the functional problem that you anticipate?
So this is at the angle of the mouth, and post resection, it will either be like segmental mandibulectomy along with the skin loss, and the angle of mouth will also be going, and the buccal mucosa. So we are expecting that post operatively this patient will have persistent drooling from that side.
Very good. So there will be lip competence issue and there will be drooling. Okay.
Yes.
Everybody agrees. Can you do something in reconstruction that can help us minimize that? What are the steps that you can take?
Sir, actually, sir, there are two aspects, sir. One thing is we can do an S-lander flap.
Okay.
That will that will give an adequate mouth opening.
Right.
However, patient will develop drooling.
Okay.
Second thing, we can go with bilateral nasolabial advancement,
Okay.
which is called carapanzic flap. It will keep lip competency. However, there would be a microstomia.
Okay. Fine.
So we'll have to balance which is better for the patient.
So point well taken. So when there is a lip defect, either you can mobilize lip in a various ways to have end-to-end lip anastomosis where competence would be good, but because part of lip is gone, there will be microstomia. At the same time, if you bring in foreign tissue like a radial forearm or an ALT or PMMC, there will be adequate mouth opening, but the competence won't be there because the orbicularis oris muscle has not joined to each other. Okay, so we have to balance between this. So you can see one of the photographs where there's a big lip defect with some kind of trismus. So what we did was use a flap, but one thing we can always use is a facial atta as a sling, which you can tighten so that there is adequate mouth opening. At the same time, the drooling will be minimal because you have given a secondary tightness through a facial atta sling. Now coming on to Dipali, what are the type of exercises that you would recommend, or what are the corrective measures if patient comes to you with a drooling?
ओके जब भी पेशेंट्स ऐसे कंडीशन में होते हैं तो हमें उनको जेंटली इन अ फर्स्ट वीक और सेकेंड वीक वी हैव टू डू जेंटल exercise so patient can movement and after then जो पेशेंट्स होते हैं उनको जो मूवमेंट्स होती है वो रिस्ट्रिक्ट ना हो जाए, जो माउथ लॉक जो हो जाता है, जो ट्रिस्मस भी बोलते हैं हम, सो उसके बाद का जो रेडिएशन के बाद भी जो हो जाते हैं कॉम्प्लिकेशन, सो प्रायरली हम इसको प्री में जो हम कर लेते हैं तो वो उसको बहुत बेनिफिशियल रहता है इन द क्वालिटी ऑफ लाइफ इम्प्रूवमेंट. और सेकेंड थिंग कि पेशेंट को जब फीडिंग का जो इश्यूज़ होता है बाद में तो वो इश्यूज़ भी उसको ना हो. सो वी कीप ट्राइंग टू डू के आफ्टर सर्जरी पेशेंट्स
Point well taken. Okay. Akshay, you have any comment on this?
सर यस सर कि इसमें अगर हम ड्रूलिंग भी इफ देयर इज़ अ मिनिमल ड्रूलिंग और एंटीरियर स्पिलेज व्हेन द पेशेंट इज़ swallowing, सो पेशेंट को हम swallowing postures हम सजेस्ट करते हैं ताकि इट बिकम्स वेरी मच ईजी फॉर द पेशेंट टू
So very important point, swallowing posture. Okay. So we have to make sure that patient doesn't feel embarrassed when he is eating. So one thing is you just ask the patient to look up and eat. There won't be any drilling. Second thing is there are a couple of photographs. You ask patient to whistle or try to blow the mouth. That way the remaining orbicularis or oculi muscle will try to get hypertrophied and maybe compensate for the lip defect. So what we have to learn from this exercise is you can predict, plan in reconstruction, as Keur said. At the same time the rehabilitation expert said you have to find a way to correct that. Because we are short of time, I'm going to go little fast. Let's go to case number 2, which is our bread and butter problem. Patients with significant submucous fibrosis needing surgery, resection of buccal mucosa. First thing, surgeons, Natasha, would you prefer to do so if mandible is not involved, like in the first photograph? Would you do a marginal mandibulectomy or segmental mandibulectomy?
So sir, if it is not involved, I will not go for a segmental.
Even if patient has a bad trismus?
Even if patient has a bad trismus, I will do coronoidectomy, L-shaped coronoidectomy with marginal
L-shaped
mandibulectomy.
marginal.
L-shaped marginal,
Okay,
but
good.
not segmental.
Okay. Shivam, same?
Sir, I agree with Dr. Natasha. L-shaped coronidectomy with temporalis release, we can
fine.
do that.
Anyone else? Yeah.
If there is SMF on contralateral side, I would counsel patient for contralateral
Okay,
side
so
as well.
and whenever you do SMF release on the contralateral side, always put a skin flap, right?
Yes.
So nasolabial or
It has to
something.
be into.
Anyone else has any comment? Priyank or anyone? Would you do a marginal or segmental? Marginal. Okay. So for me, if the lesion is anterior, I would try to do marginal. But if the lesion is posterior, not involving the bone, because my resection will also include part of masticator muscles, which will again cause post-op trismus, further trismus, I generally weigh between marginal and segmental. We all find it difficult to remove mandible if bone is not involved, but sometimes for overall functional gain, if patient cannot operate mouth, absolutely Priyanka, what's your feeling if we do a marginal mandibulectomy and give radiotherapy? How much trismus do you expect, or do you have anything in radiotherapy techniques that can prevent that trismus?
Radiation is a consideration for patients that the answer lies in the histopath report. So if it's an advanced tumor, T3, T4 node positive, depth of invasion is more than 5 mm. In such cases, we consider radiation. And most of the patients, yes, they do develop trismus during RT also, and even after RT. And additionally, they have submucosal fibrosis, so that is also one cause. And I encourage all these patients to exercise during radiotherapy.
Very important point.
But after 1 or 2 weeks of radiation,
Yes.
they develop mucositis, and it is very painful
So
for
what-
them to
yeah.
follow
Thank you.
the exercise.
Thank you very much. What she said is a very important practical point, that patients will develop, if you do marginal, particularly in a patient with submucous fibrosis, bad trismus during and after radiotherapy. Even though you encourage them, which is the right thing to do, to continuously do mouth opening exercise, as we have showed in the photograph, most of them will stop after a couple of weeks, and they will end up with a significant post-radiotherapy trismus. So again, if you know this entire sequence and you have seen many patients who cannot open mouth at all after radiotherapy, you should keep in mind that sometimes it may be better to do segmental instead of marginal. So both options should be open in your mind. Now, Dipali, what sort of protocol would you give to patients specific to trismus post-surgery?
ओके जब ट्रिस्मस पेशेंट को होता है, सो वी हैव टू डू ऑल द माउथ ओपनिंग एक्सरसाइज फर्स्ट. सो ऑल द की पॉइंट्स ऑन द लॉक जॉ. सो patient must be actively do every 2 hours exercise, because
First
अगर वो
point,
नहीं,
every 2 hours mouth should be stretched.
yes,
Important.
every
Second,
muscle should be work, because after अगर पेशेंट 1-2 बार करेगा दिन में, तो वो कुछ नहीं,
so
उसके
बहुत
वर्थ ही नहीं
important
रहेगा
point,
उसके लिए.
Protocol should involve at least mouth opening exercise once in 2 to 3 hours. Number
या
one point. And
और वो दिन में एटलीस्ट मिनिमम 5 to 6 टाइम होनी चाहिए.
Perfect.
और ड्यूरिंग वो जो पेशेंट खाने के लिए अगर कुछ कर रहा है, तो बिफोर टेकिंग द फूड दे शुड बी
point very well taken.
Yes,
Okay, good.
mouth opening. The stick exercise also, dynasplint using, they can use,
Okay,
or
good.
therabite
That's
also.
right. Thank
Yeah.
you. Akshar, you have anything else to add to? Okay, good. So that's very good. So again, summary, try to use your surgical knowledge to prevent post-op and post-radiotherapy trismus while you are operating, and post-operatively start aggressive mouth opening exercise immediately in a post-op phase, and make sure it happens frequently. Now, third case, we have done a segment mandibulectomy, the recovery has happened, but lower jaw has deviated to the opposite side. Okay, number one, is there anything, Shivam or Natasha, that we can do intraoperatively to ensure that this is minimized?
So, sir, intraoperative, if we are doing a hemimandibulectomy on one
We are
side,
not going to do fibula because lot of soft
Yeah.
tissue, we are going to do soft tissue.
soft
flap.
tissue reconstruction.
Okay.
So we can get an impression done at the same time only,
Okay.
because later mouth opening can become a limitation. Otherwise, we don't practice it regularly, but if we put IMF screws and later we can guide it through elastics into occlusion. But we are not routinely doing it, because if we take impression, guiding flange can be an option.
Okay, so 2 options. One is guiding flange, where you take an impression, and post-op you can use that. Number 2, you can put interdental wiring, the arch bars, and then use elastics to do that. Shivam, anything else? Keur, you want to make any comments? Anything else?
Sir, I think
That's fine, right? So now, okay, both of the things did not work. What are the exercises that you can teach to your patient कि उससे वो सिर्फ सेमी सॉलिड नहीं, थोड़ा सा हार्ड फूड भी खा पाए? दीपाली एंड अक्षर.
यस सर. फर्स्टली उनको जो माउथ, जो हमारा फेशियल मसल्स जो होते हैं कट हो जाता है, जब डिसेक्शंस होता है तो मसल्स कट हो गए. सो उसमें क्या है कि मसल्स को स्ट्रेंथ पहुँचा करने स्ट्रेंथनिंग एक्सरसाइज करवानी पड़ेगी उसको। फिर अगर लिम्फेटिक नोड डिसेक्शन हुए होंगे तो डेफिनेटली देयर इज़ अ पॉसिबल चांसेस रहेंगे कि उनको लिम्फेडिमा प्रेजेंट रहेगा।
Okay,
So
let's
that-
specific stick to jaw deviation. We'll go to
Okay,
lymphedema.
okay.
Is
Jaw
there
in a
any
jaw
exercise
deviation.
that can
Yeah,
replace
in a
the-
jaw deviation, we can refer the patient compression garment during night time.
Okay, very good.
Yeah, so that is the main important role of compression
So
garment.
while patient is resting, if you can use a compression garment which keeps the jaw in alignment,
Yes.
that's fine. Anything, Akshay?
I agree with Dr. Dipali, and after the jaw एक बार set होता है, then I will refer the patient for dental rehabilitation, so
Okay,
that
very
in
good.
future patient
Yeah.
can have soft
Yeah.
diet.
So all the points well taken. One thing that we do is we ask the patient to use the force of the hand and make sure mechanically it shifts the mandible onto the opposite side while they bite. You keep doing this exercise. If he does this very frequently, automatically body gets used to that, and then they can even eat sing chana and the hard stuff pizza and all. So this is something that all can try for those patients. Now let's go to the tongue defect. So divide the tongue into two type of defect. One is an anterior defect and one is a posterior defect involving base tongue. Again, when you have a defect like this, say hemiglossectomy or a lateral 1/3 tongue resection, Shivam or Natasha or Kiyur, what's your experience? Should we do flap or we should just leave it raw? Say it's 1/3 defect, not like a half, but say 1/3 defect. What's your experience?
Sir, if the tumor is located on the lateral, just the lateral, and there is no, just the middle third of the tongue is going and there is no extensive tissue loss, then we can avoid a flap.
Okay.
We can suture close and we
Natasha?
can proceed.
So up to 1/3 defect, it is choice. We can
Okay. So either way is
yeah,
fine.
either way is fine.
Kiyur, you have?
Sir, the problem with tongue is, sir, it helps in swallowing, and another is speech.
Yes.
To reconstruct with to give a complete tongue will at least keep speech intact and a bit of swallowing. For per se, as a plastic surgeon, for hemiglossectomy, we always go for a flap.
Okay, good. So the take-home message is, if it's a very small T1 lateral defect, you can observe, but if it's reaching to a hemiglossectomy, it's better to reconstruct. Akshar, you do a lot of work on swallowing and speech. What's in a post-op? What these type of patients see? What are the common problems that they face, and what are the solutions for them? Anterior tongue. I'm not talking about base tongue.
You're talking about the anterior tongue.
Yes.
Okay.
Kind of.
So,
So
for this
line
type-
of lateral tongue, not involving base tongue. So aspiration is not a major concern, but
Correct.
it's more speech and the kind of
So
stuff.
अगर if we take this type of case where a lateral border of tongue is involved, so sometimes what happens is कि patient the tongue movement, the upper upright movement, it gets little bit of affected. So because of what, the speech intelligibility, यानी कि जो साफ बोलना होता है उसमें वो प्रॉब्लम आ जाता है. सो इन दैट केसेस, इन दैट टाइप्स हम पेशेंट को टंग एक्सरसाइज सजेस्ट करते हैं, एंड समटाइम्स वी आल्सो गिव देम द swallowing exercise such as supraglottic swallow maneuver. So if in case patient have some kind of micro aspiration also, so it will have the patient.
Perfect. Very good. So perfect. So see, always remember, anterior tongue, the emphasis is more on mobility, as Akshar said, and in a posterior tongue, it's more on volume. Because posterior tongue deals with aspiration, swallowing exercise, and anterior tongue with movement. So after tongue, do a flap or don't do a flap. Encourage patients to start doing tongue exercise. Bring the tongue out, touch the palate, left side, right side. So while it's healing, it's still mobile, and that will give tongue little bit more. Yes, Sandeep bhai.
With local flap, sir.
Any flap.
If there is no flap, the tongue mobility is very much good. If I have in my experience, so there is very less difficulty in speech as well as in swallowing. But in terms of if there is a flap, partial glossectomy or hemiglossectomy where the defect is more, it depends on the कितना resection हुआ है. So if it is
Yeah. So very important point. Contrary to conventional belief, Flap always never improves speech outcome. It depends upon the size and volume.
How much is it has been removed?
Sometimes if you, for a small defect, if you put a flap, it actually holds the remaining tongue back and it doesn't move. So very important to plan looking at your defect. If it's a larger size defect, you need some volume, so you have to put a flap. But as Sandeep Bhai and Akshay said very rightly, if it's a small defect, sometimes just leaving it raw and improving the tongue exercise will give you a better speech outcome. Now, because of lack of time, we'll move on to a total glossectomy defect where we have removed the base of the tongue. The biggest concern is aspiration and swallowing. And just because of this aspiration and swallowing, most of us surgeons, we do not operate these patients because patient is tracheostomy and PEG dependent. Anything Natasha and Shivam you can do to prevent this aspiration during intraoperative? Choice of flap or some other maneuver?
Sir, hyoid.
Hyoid change.
Okay, so very important point, how it will work. Can anyone elaborate? So hyoid suspension is what suggested by the surgeons. How it will work? What you do in hyoid suspension?
So laryngeal inlet,
Yes.
we are advancing.
So what we do is take a ethylone 1 number. You can see in this photograph. Put it around the hyoid both the sides and then make a hole in the mandible and then tie it. So hyoid is suspended anteriorly and upwards. So the larynx pulls anteriorly and the esophageal inlet will open, and larynx while we swallow is protected because it is put up and anteriorly. So this is the single most important maneuver that will help you in a post-op swallowing rehabilitation. So that's number one. Keyur, what would you prefer in a reconstruction, a PMMC or an ALT for a major glossectomy?
Sir, ALT, I would prefer ALT because we can design a lotus-shaped flap, so which will give a bulk which
in
will
the posterior palate.
and it will also cover the base.
Very good. So the thing is ALT, sometimes if you really want to pull the hyoid anteriorly and tight and the space is tight, the ALT pedicle can get compressed. So again, look at the defect and how much space you have. Always prefer flap is a second choice, hyoid suspension is first. This is based on my lot of experience of doing these procedures. So PMMC with hyoid suspension is better than ALT without hyoid suspension. Okay, so just remember that. Now I'll come to Akshar. Akshar, this is the most difficult problem we all face. So you have to tell us what are the investigations briefly and what are the maneuvers that you do. How do you rehab these patients with a significant aspiration?
First of all, जब भी patient comes with a total glossectomy, so the major concern is with the liquid aspiration. कि patient पानी पीता है तो तुरंत ही aspirate करता है. So my first protocol will be I will be doing a fiber optic endoscopic evaluation of swallowing with different liquid consistency, for which I use a thickener, जिसमें what I use water or dahi with different consistency, and I check whether of किस consistency में patient is able to swallow or and try to avoid maximum aspiration. मतलब aspirate ना हो, I have to look at that. And the thing with supraglottic swallow maneuver, and इसमें oral phase dysphagia होने का सबसे ज़्यादा problem होता है because push back the propulsion होता है oral, तो that is also very much affected. So first I will give the patient an effortful swallow. Secondly, I will be giving for safety and efficient swallow. So I will be suggesting supraglottic swallow maneuver to the patient.
Can you briefly describe supraglottic swallow maneuver?
Supraglottic swallow maneuver, it comes in the 4 steps. The patient को हम पहले बोलते हैं, he patient has to take a little bit deep breath. Secondly, patient has to hold his breath. Third, patient has to swallow his own saliva, and he has to release his breath. So with this, with the help of bolus, patient को हम बोलते हैं कि आप मुंह में पानी थोड़ा सा पानी रखिए. Then patient has to take a deep breath, hold, then swallow 1 and 2 times.
So very important, supraglottic swallow. Second thing in practical life, if you have said one side of base tongue, you make the patient tilt the head on the other side, rotate it backward, and ask them to put the food on from the normal side. Sometimes that also helps.
Correct.
Again, very important about various consistency of food. Sometimes patient will aspirate on a liquid food, liquid diet, but they can swallow semi-solids. So you have to tighter your swallowing journey based on what What type of aspiration?
For liquid to control for the liquid aspiration, there is a powder also called Nestle thickener. Yes, so उससे क्या होता है कि we make the thin water into nectar or honey consistency, जिससे patient normally पानी भी पी सकता है and we can avoid aspiration for longer time.
Very good. Thank you, Akshay. So now let's get Priyanka onto and then Dipali. This is, we all see on almost 90% of the patient, post-radiation side effect. The first is mucositis, second is skin, and third is dry mouth on a longer term. What's your advice and how will you manage?
So the first two, mucositis and dermatitis, are more like acute reactions rather than post-radiation late complications. Mucositis we usually manage with topical agents, and if required, sometimes in grade 3 mucositis like this, we add analgesics also. And in dermatitis, we also use topical agents, creams containing aloe vera. And xerostomia is a late effect of radiation. So it is said that it is better to prevent xerostomia rather than later on treating it. So we see to it that we restrict the mean dose to each parotid to less than 26 gray mean dose. And in case of xerostomia later on, there are various ways to manage. Some are effective, some are not. Like for example, we give salivary supplements, sprays. We give saliva producing cialogogues, pilocarpine, civamelin. And also, if that also, that sometimes that never works, but I tell my patients to suck on something that is sour and sweet and sour, and chewing gums. That sometimes works miraculously rather than these medical supplements.
Really appreciate pinpoint things. So mucositis, just 2 minutes. Mucositis is very important to ensure that patient keeps drinking a lot of water while they are undergoing radiotherapy. If it's real high grade, you can use xylocaine viscous while before eating food. Use rice tube if required. Same with skin. Again,
I will just want to add one point that I totally agree कि we suggest patient to drink continuously water. So मैं तो patient को ये बोलता हूँ कि आप पानी पियो ताकि एक तो salivation रहेगा और secondly it will help as a swallowing therapist कि patient का swallowing चालू रहेगा.
So very important. Now last, Dipali, radiotherapy, specific neck fibrosis and lymphedema. Just 2 points and then we can close because the time is up.
Okay. When patient has a fibrosis, so we have to break the fibrosis. How? But how? तो वो हम मैनुअल लिम्फेटिक ड्रेनेज जो CDT प्रोटोकॉल, यूनिवर्सल ग्लोबल प्रोटोकॉल है, CDT प्रोटोकॉल. सो वी हैव टू डू मैनुअल लिम्फेटिक ड्रेनेज फर्स्ट, then exercise, then compression. Because if there is a fibrosis, skin hard, और जब पेशेंट का जो स्किन ड्राई हो जाता है तो स्किन फट जाती है, वो ब्रेक हो जाएगी, सो ऊजिंग होगा. सो इन दैट केस वी हैव टू मैनेज द स्कार, वी हैव टू डू स्कार मैनेजमेंट एंड देन वी कैन गो फॉर द मैनुअल lymphatic drainage.
So very good points, all well taken. Now because time is up, I'll just quickly run through dental rehabilitation. Anyone in the audience or here has an experience of putting dental implants with fibula for cancer patients? Anyone? Dakshesh? No? Priyank? Anyone else?
In amyloblastoma or in benign.
Nah, that's what I said, cancer. We are, yes, Keur?
Sir, intraoperative, not in cancer.
Okay.
But post-operatively, very few patients turn up for dental treatment.
Yeah. So see, still kind of an open area. We don't know certain points. If you want to do dental implant, you need a good bone stock. So either you have to do double barrel fibula better,
Yes.
or iliac crest has a good cancellous bone, but it's a difficult flap to use. Again, maybe use 3D printing to have accurate occlusion, so that once you put a dental implant, it's actually been used. Again, debate in radiotherapy, when should you put an implant? If you put intraoperatively, while the type of radiotherapy, will they develop osteoradionecrosis? If the flap fails, what will happen to costly implants? If you do later, as Keu rightly said, most of the patients will have so much mucositis that they will not turn up for implant at all. In maxilla they do zygomatic implants, and I think that's slightly better because slightly away from the area and it's not that expensive as well and easy to put. Just concluding, I'll say it's not only the physical rehab, but it's the emotional aspect as well. No matter what we try as a team, patients are never going to feel back to what they were before. So it's important for us to work towards making them accept the new normal. I always tell the patient, you cannot compare your previous life to this life. Focus on that you have cured and you are alive. That's a big miracle. You had cancer. And at the same time, we keep on working towards solving their rehabilitation issues. Last thing, the rehabilitation is one of the most neglected aspect in cancer care in our part of the world. It's very well developed in Western world, and again, it cannot happen by one person. Right? He has put up a fantastic panel covering all aspects of the specialties here. So also you should try and build your own team. It's not always easy. Many people work at various places, but find a way that every single patient is attended by a team of experts doing their own job. How do you do it? How do you build that team in your scenario is up to you, but try and not to ignore this aspect, because not only from patient perspective, the patient experience you improve, your practice will also improve, because that's the most important aspect that patient perceives. उसको खाना नहीं खा रहा है या कुछ प्रॉब्लम है तो उसके लिए वो बहुत बड़ा प्रॉब्लम है. So with this I conclude, and I again thank everyone for inviting me here. Thank you.